Well, regarding the activity of systemic treatment in HER2-positive breast cancer, need to remember that brain metastases are quite common in patients with metastatic HER2-positive disease. So, but 40 to 50% of these patients will develop brain metastases during the course of disease. And of course, we have excellent local treatment options available, such as stereotactic radiosurgery. But systemic treatment options are also needed in order to improve intracranial disease control and also offer extracranial disease control in parallel. And then, of course, we want to use systemic treatment to delay or avoid wherever possible whole brain radiotherapy with the severe late cognitive side effects. And in this context, it is important to remember that HER2-positive breast cancer really is a model disease because we have systemic treatment options available here. And these, of course, are small molecule tyrosine kinase inhibitors, for example, third generation TKI Tucatinib, based upon the results of the HER2 CLIMB trial. And again, please do remember HER2 CLIMB was the first pivotal trial, including a relevant number of patients with active brain metastases, so newly diagnosed, not previously locally treated, or brain metastasis progressing after prior local therapy. So this is really important to remember. And this is something we would all love to see in other phase 3 trials as well. And then, of course, we meanwhile know that also large molecules such as antibody-drug conjugates, especially Trastuzumab deruxtecan, the third generation ADC, has considerable activity in brain metastasis as well, because at the metastatic site, the blood-brain barrier is substituted by a more permeable blood-tumor barrier. And we have seen response rates, initially in smaller phase 2 trials and more recently in the large prospective single-arm 2-cohort DESTINY-Breast12 trial of around 60 to 70%, which is clinically, of course, highly relevant. So in summary, there is a role for systemic treatment of HER2-positive breast cancer brain metastasis. We have drugs that are highly clinically active. Of course, we need further treatment options after the exhaustion of the currently available options. This is definitely one of the challenges. The main challenge, however, I believe, that is we need to identify options to prevent the onset of brain metastasis. I guess that would be the holy grail in this field in order to reduce the morbidity and mortality linked to the development of brain metastasis.